खाना भी तो सब और आयुष्मान कैसा
Hi, Atul. Good to see you. You just need to unmute yourself.
Good morning, Solomon. Good morning, Atul.
Good morning, Mike. How are you?
Good, good. I guess good morning my time, though, right?
Yeah, it is afternoon here.
Afternoon, that's right. How are you doing?
Not too bad. I think we're just going to unmute Atul and see if we can get him to speak as well. Yes, here you are, Atul.
Yes, Mike. Hi.
Yeah, Atul.
How are you, Mike?
Good. How are you?
Going on and relaxing a bit too much.
Yes, exactly.
Hi, Mike. How was camping?
Hi, Paolo. How are you?
Very good, very good.
Good.
Hi, Paolo. Good to see you.
Hi. Good to see you.
Okay,
Hi,
so I think we have got a couple of minutes to go. Is Lily already in? Let me check.
No, sir, she's not in.
Okay. So basically, okay, we have only 30 participants, so we can explain after we have some more participants. What we're going to do is we have obviously Mike's lecture, we have discussion to follow, and after that we're going to do a trial run of the quiz. And this part of the quiz that we'll be doing trial run is actually to downsize the number of participants that we have. So we have about 600 plus participants for the quiz at the moment, probably more, because this is what I'd seen 3 days ago, so I don't know how many there are at the moment.
Wow.
So what we're going to downsize them on a day before our main meeting, and we're going to announce the 10 participants in our main meeting that these will be the participants, and then we play with them on the last day. And that quiz will be actually an interactive quiz. This quiz is more of a computerized quiz. We were trying to play Jeopardy, but we can't since the numbers are huge. But I'm sure we can persuade some computer geek to see if we can run it in some way that it gets interested. So we look into that. So we'll discuss that in our board meeting, which follows after the quiz. I spoke to Doug just now, and he's joining as well shortly, or already joined. I don't see him.
I don't see him on. I'd send him a text message, but I didn't hear back from him yet.
So we have somebody. Yeah, I just spoke to him 5 minutes ago. So we have Pragnesh Bhatt from Scotland who's saying hello, and Lukman Hadi from Indonesia, and Nicholas is from Greece, and we have Galaxy J5 from Saudi saying hello.
Wow.
Okay. So how was camping, Mike?
That was fantastic. Yeah, it was great. We went for the whole week. Just got back, so it was a good, relaxing time.
Where did you go camping?
We went to a spot in Pennsylvania near Pittsburgh. So it's about maybe 3 hours from here in Pennsylvania, kind of the woods. It's got a funny name. It's called Ohio Pile, but it's got a big river that runs through it. So you can do whitewater rafting. Have you ever been whitewater rafting? We did that. We did some fishing, some hiking.
Brilliant.
So it was fun. Good fun.
Did you catch anything?
Yeah, it's a few. It was slow. The water's really low. It's so hot. There's the big droughts. So, but it was good fun.
So are you showing some pictures from there today?
No, huh? I should.
Oh,
Not prepared.
With the Zoom. Zoom.
That's right.
Okay, so we have Lily Paolo already in along with Doug. Doug has just signed in as well. So is Sandeep here?
Mm-hmm.
Sandeep is there, yeah.
Okay, brilliant. So, Atul is there. So we have all our friends already in. So I think I would leave it to the moderators to start. Lily, just briefly, what we're going to do is we're going to have Mike's talk and then discussion to follow. And following that, we're going to, one of my residents is going to play the quiz. It's a computerized quiz on a link called Hoot, and we'll share the link on the chat so people can go on it with their cell phones and can answer questions accordingly. And we're going to do 30 questions and select top 10 people. And then from those, we're going to have another 10 questions. And then the first 3 would get a certificate for achieving first, second, and third. Unfortunately, we can't give them a prize through this at the moment. It's all yours, Lily and
All
Pavel.
right. So we'll begin this morning by introducing Dr. Mike Steinmetz. Mike Steinmetz is the wonderful story of a student superseding all his masters who came and taught him. I met Mike first as a resident at the Cleveland Clinic, and he has gone on to become our chairman at the Cleveland Clinic. He is professor and chair of the William and Amanda Mader, is that correct, Mike? Mader?
That's correct.
Endowed chair. He has had numerous and continues to have huge roles both nationally and internationally. And today it's my privilege to introduce him to present on robotics and spine surgery. Mike, take it away.
Thank you, Lily, and thank you to the board for allowing me to do this. Let me just share my screen and make sure that you guys can see this. Okay, so hopefully my screen is up.
Yep.
Okay, all right. Well, again, thank you to the board. Thank you, Lily, for that introduction. And it's my pleasure to give this webinar presentation on the future of spine surgery. And I put in question mark robotics, because I think we're currently in the sort of wider spread use of these technologies. But again, I think we question, is this really going to be the future? You know, what does this look like? We're kind of really still in the infancy of the use of robotics in spine surgery, certainly here in the United States. And my disclosure is none are relevant to robotics for this presentation. Now, I think as we all know, robotics are not new in surgery in general. When you look at the Da Vinci robot platform, it's really the dominant platform in prostate surgery, heart surgery, a lot of GYN and colorectal surgery. So many areas you could consider really this platform being the standard of care. So this is not a new issue in the surgical realm. And even in neurosurgery, robots have a big role, especially on the epilepsy side, where robotic usage is very common for placement of SSEG electrodes. In many cases, robotic arms have been used for access guidance into the brain. So again, not new. And when we look at all of the surgical robots that are out there, and this is an older slide now, a number of years old, but you look even at this point, there were 34 robotic devices out there for all areas of the body, and they continue to grow and see more widespread usage, and even in the spine as well. And really, why is it happening? Why is it happening right now? Well, one is, again, the robotic market is expected to explode over the next number of years. And we see this certainly in the US and probably throughout the world, where as these robots have come online, people are buying them, and there's a lot of excitement on the financial end of this. So the current, this is again a little bit old, this was 2016, but the current market was about 32 or 26 million. And I got this video screen covering my slides here, but it's expected to be worth about 2.7 billion when we get out into the future. So that market is expected to really expand. And again, there's a thought that when you get about 35% of penetration in a country, then many surgeons will demand this to be sort of the standard of care that will drive growth. And again, as we're starting to see, certainly in the United States, reduced payments for the surgeries that we do, many of the hospitals are looking at ways to increase our efficiency and improve our outcomes, or at least make our outcomes more predictable. So the financial drive of this, perhaps us as surgeons wanting to use this and saying that maybe this is more of a standard of care, and if this provides some efficiencies to surgery, all of those are sort of this perfect situation where we're really driving robotic usage into the future. Now, when you think about this, certainly we've got to sort of make an argument of why we want to use robots. And certainly in the US and probably many places in the world, marketing is really a driver of this. And we see this here, you know, we have not been able to fly on an airplane since march, more or less. But if you get into an airplane, say United Airlines, which is a common one we fly out of Cleveland, you see articles like this in the airline magazines, featuring a spine surgeon holding one of these spine robots and advertising as a way to attract patients. Again, all patients are looking for less invasive surgery. And if you can do that with a robot, you can use this as a marketing way to get more patients to you. And again, there are some clinical advantages. We'll go over this in greater details. But again, you could argue that I want to reduce my radiation exposure, or I want to have a more effective way to do surgery efficiently and safely. Then you can use these arguments as well as a way to try to obtain these expensive devices. But I think what we see a lot here in the US is just every hospital is acquiring them and then putting up signs around the town advertising, come to our hospital because we have a robot, and then simply another hospital buys a robot and then buys a robot. And so this is really what's driving a lot of the usage here around us, is just sort of so-called keeping up with the Joneses, is a way to just not be out competed by your surrounding facilities. Now, I want to take a step back and just talk about sort of evolution here. So when we look at spine surgery, especially on the technology end, we've seen a fairly significant evolution over the last two decades and even more. If we look at just minimally invasive surgery going back to the 90s, we started using this technology to apply to the spine for removing herniated discs in the lumbar spine. And perhaps this is one of the ways where it became popular, certainly not where it started, but one of the ways it became very popular and applied to the spine. And again, the whole goal was to try to minimize a lot of this post-operative morbidity with larger surgery. This was some of the drive to do this minimally invasive. And again, it was largely applied to the lumbar spine for degenerative reasons, herniated discs, stenosis. There were improved perioperative outcomes. When you look at the literature across the board, perioperative outcomes were better, sort of harder to prove on the long-term outcome end, but certainly in experienced hands, no increase in complications. So this really set a foothold in the spine world. And then we look at where we apply these now, and this is just a minimal way to do this. We can now apply not just in herniated discs in the spine, but readily apply these to the cervical spine. We have Dr. Goel on certainly ways into the craniovertebral junction, the thoracic spine. Now with percutaneous screws, we can place those throughout the thoracolumbar spine. We can control deformity, even with adding lateral approaches. We can correct the sagittal plane. That was the downside of percutaneous screws early on for deformity. But now with anterior column releases and anterior cage placements plus percutaneous screws can have a better impact on deformity, and then usage in sort of the elderly or the frail patients as a way to provide rapid fixation and early mobilization. So this certainly has evolved fairly significantly over the last 20 years or so. And in that same vein, we've seen a fairly significant evolution in image guidance. This has almost become a standard of care to some extent, without being a standard of care in the minimally invasive realm, where we've moved away from two-dimensional thoracoscopy into things like three-dimensional thoracoscopy, true CT scans like we see in this one, or pseudo CT scans like we see with this device. But here, we're able to render a 3D picture of the spine and perform very rapid and accurate image guidance, sort of image acquisition obtained on the fly and applied to the spine very quickly, very rapidly, and very effectively. And again, this has been another rapid or another significant evolution in spine surgery, and allowed us to do things less invasive, safer, and then step away from fluoroscopy as one of the biggest advantages of that. Again, here's just in one of my cases doing a cortical trajectory screw, where we can just very easily, through a small incision with these navigation units, obtain an image like this, like a CT scan image, and apply them to the spine in a less invasive yet rapid way. We've seen even evolutions in OR imaging. So this is an exoscope that I was using to do a decompression on. Again, the ability to use these glasses not have to look through the microscope, but look up a bit at a larger TV screen and perform this operation without bending your neck, looking straight up, good line of sight, good ergonomics as an effective way of doing this operation. And again, in that continuum of evolution. So we are sort of exploring, discovering and innovating as we move through the years doing spine surgery. And here's just an example of something that maybe a lot of you do, but again, as a way to take this to the next level. And this is doing, an intradiscal transforaminal interbody fusion. So combining this with endoscopy, we can work through an 8.5 millimeter endoscopic portal. And this is true percutaneous fusion. And I think the benefit here is we can do this under local anesthesia. So again, just another evolution as we've seen in the minimally invasive realm. And so we can work through a very tiny incision, not more than 9 millimeters, true percutaneously. I don't show the endoscope here, but combined with endoscopy, we can decompress, we can visualize, clean out the end plate with tools that are provided in the set, and then place an expandable cage in the disc space and then deploy it. So again, just showing that we've had fairly significant evolution over the years in our surgical techniques and technologies, and robotics is probably that next level of evolution. This is going to allow us, I think, to take open, but to probably a greater extent, less invasive surgery to the next level in our treatment armamentarium. Now, in the United States, we have 3 robots that are cleared by the FDA. They are all very similar. They all have a robotic arm. They all have removable end effectors for different tools on the end of the robotic arm. They have a computer system to guide the robot. They have integrated navigation, which was an upgrade from the previous versions of these robots, where they simply had a plan and they placed wires in the spine, and then you could place screws over the wire, say using fluoroscopy. Now the systems have integrated navigation where fluoroscopy is now essentially not needed for this. There are some differences in how these robots are fixated to the patient. Some are fixed to the bed, say, for example, the Medtronic Mazor X, which is locked to the bed, and other are fixated to the floor, like the Globus robots or the Zimmer Biomet robot, which are fixed to the floor. But otherwise, they're fairly similar units and do have fairly similar functions. And here's just some of those robots with the Zimmer Biomet ROSA robot. If any of you that are neurosurgeons use the ROSA for SSEG, that can be, as far as I understand, CrossFit to a robotic arm, but they've coming out with a newer version that will be a solo robot for the spine. The Globus robot, again, these would both be floor mounted or floor fixated. They don't fixate to the patient's bed. The Mazor robot here, where the arm is fixated to the bed. And this is just an example of an additional robot that I don't put in these 3 robots up here. This is more of a passive arm, which is part of the BrainLab system. I don't have the name of this robot right off the top of my arm, but essentially it just holds a navigation plane in place, but you move it to line up your navigation arc and you let go of it and it holds it in place. So more of a passive robotic arm. And some companies and other companies have these out as well that can aid in a navigation plane for, say, a screw or a K-wire, but don't have the same functionality as these integrated navigation units you see from the other companies. And all of them work in a similar fashion. So, for example, planning can be done. And the benefit here, I think, is planning can be done ahead of time. So if you use a preoperative CT scan, as you would in, say, navigation, you can plan the entire operation out before you do the procedure. And you can make fine-tuned movements to your hardware. So here's just a quick video of planning screw placement. You can see a virtual screw being placed. And then you can do fine movements to the screw to get it exactly where you want it, length, height, width, angle, etc. You can plan the right side, you can plan the left side, and you can get essentially your whole construct planned out ahead of time, and then return to the patient and then actually execute your plan through the robot as you move forward. Now, again, you can do this live during surgery too. So if you use an intraoperative image acquisition system like the O-arm, you can obtain this imaging and then plan it on the screen in the operating room, or you can do it ahead of time, say the night before. You could work with your trainees, for example, and really come up with a sound construct, and then return when you bring the patient to the OR the next day, and then you can plan out your operative case. This is a promotional video for the Mazor system that I'm going to turn my sound off for a second. Hopefully this does not play the sound. That I just want to show. Just get it down into the system. Just some of the basics of the system. Just if some people on this webinar are not used to seeing what these robots look like, let me get this to the right spot here, and then I'll stop. So this is, again, just a video, promotional video, looking at the robot. Again, some of the ways you execute it. You have a plan. You can move through certain steps. The robotic arm comes down. You can drill through the arm. You can place screws to the arm. And I'll show a video next of doing this live. You have an ability to make sure it's accurate. So you are tracking the movements of the robotic arm to ensure its accuracy as you go through. But you can see an idea of how that system works. And here's a video of just using one of the robots to place screws in the spine. So the plan is already in place. Oops, sorry about that. That did not play. But here, skin is being cut so that the trajectory is already lined up through the pre-planned trajectory, working through the arm. Then a drill can be placed down. And you can see that the arm is checked by the computer to make sure accuracy, and then you have live navigation, so the tools are navigated as well and integrated. So you can drill a hole, then you can tap the hole, and you can see that live with navigation. They're following the tap down on the screen live, and then after that, the appropriate screw can be placed into the spine. Again, using navigation, again, that you're not only ensuring accuracy by the robotic arm being tracked and being accurate, but also you're live navigating it as well. And you can place this screw percutaneously. You can deploy it once it's in the appropriate spot here. I just want to show the robotic arm then moving. So once it's in place, screw can be left in place, and then you can hit for your next side, for your next screw. This has a foot pedal, hit the pedal, and then the robotic arm is going to move towards the opposite side and then get set up for the next screw. And you can move through the plan you did either during surgery or you did the night before to execute the placement of your screws throughout the spine. And again, it's not just screws. This is a video which I can't show. It doesn't play. But what this is a lateral. So you have a cage being planted L3-4 and L4-5, L3-4 and L4-5 on the sagittal view, and then on the axial view. And you can adjust exactly where you want the cage. How far posterior, how far anterior. Say at L4-5, you want to be a little bit more anterior. You can angle the cage. You can come up with a perfect plan of placement of these cages to try to be the most effective, the safest, and then execute that cage placement through the robot. So it's not just screws anymore. Now devices like cages can be planned on the robot and then executed through the access that you can get through the robotic arm. So I think that's just a quick overview of sort of the systems that are out there, a little bit of some video of how they work. I guess the big thing that now we've got to decide is why would we want to use a robot? And I think the top two bullets here are probably the most applicable. One would be accuracy, so trying to place those screws as accurately as possible. And I'm going to show it's more so than just accurately placing them in the pedicle, but if you can build a construct ahead of time, a plan ahead of time, so that you can see that all your screws line up, your rods will line up, you can get this to be the most accurate as possible. The whole operation can be a little bit easier. And the second thing is predictability. So right now, Even with image guidance, we do have some variability in how we place our screws, even right to left. Okay, so one may be angled up, one may angle down, one a little bit more lateral, one may be a little bit straighter. So there is some differences in how we do this patient to patient or pedicle to pedicle with image guidance. But with robotics and with pre-planning, it may be that you can create a very homogeneous placement of your screws and have a very predictable placement for your entire construct. So you know exactly how it's going to look afterwards if you planned it appropriately ahead of time. So I think those two are some of the biggest issues that we see with robots. The other thing is decreased radiation exposure. So if you use two-dimensional fluoroscopy to place pedicle screws, and you move over to robotic platform, you may be able to eliminate all of that radiation exposure. And this is what a lot of the literature out there shows, is that the radiation exposure can be decreased. Now, hopefully surgical efficiency will be seen. Now, some of the downside of robotic usage is there is a learning curve to this. So it does take time to be efficient, but to be effective, there has to be an efficiency built into this. And if you can do these over and over in a way that it becomes more efficient, then there should be some effectiveness of this. Now, one of the interesting aspects here is that surgery with a robot can be performed on a simulated placement. So you can, with the computer planning software, you can essentially perform your operation. You can put your screws in, you can line them up, you can get an idea of the rod bend. You can, even with some of the software platforms, you can make measurements of the spine. So you can design osteotomies, different sizes and angles of cages you want to place to essentially achieve the outcome that you want. So you're essentially doing simulation, which is great for training. So you could take a trainee through the entire operation, beginning to end, and then come back the next day and essentially just perform the operation through the robot. So it almost becomes a cognitive specialty. And what I mean by that is, right now, spine surgery is a very physical specialty, as we all know, right? We open the spine in a large way. It can take a long time if it's a multi-level fusion. We're biting bone with our hands. We're turning torque screws in, et cetera. So it's a very physical activity. But here, if we can plan it all and then simply execute it through the robot, now really our strength is in our cognitive ability and not necessarily our physical ability. And I sort of equate this on the neurosurgery side to movement disorder neurosurgeons who place deep brain stimulator electrodes, where the only surgical part of that is really drilling a hole in the head, and the rest of it's just sort of neurology. And they have a microdrive robot driving the electrode. And could robots make surgery that sort of specialty, where we're really just thinking about what we're doing we're planning it, and then executing it through a robot? And perhaps we could get to that as these robotic platforms continue to expand. And again, with expanded robots and technology, we can basically continuously acquire imaging. So if I want to perform osteotomies, place different size cages, I have it planned out on my simulator. I can continuously upgrade my image acquisition and see if I'm meeting plan as I go, and do I have to do a little bit more? So there is some power in these systems moving forward. And this is just an example of accuracy, where, again, it's not just placing your screws accurately through the pedicles, but you can figure out sort of how these screws will line up, what the bend in the rod is going to look like, what the angles coming out of the spine, and perhaps I've got to move this screw a little bit more lateral so I don't have such a sharp bend. There's a lot of power in the planning software in trying to make this operation as easily as possible. And if any of you are Austin Powers fans, again, I think one of the cool things of robots, it is almost like sharks with laser beams, where it's just really cool technology, and we get to apply that. To the spine. Now, what about? I'm running short of time here. What about clinical evidence? There are now a number of papers out there looking at robots, a variety of platforms that are out there. Most all of the papers have shown reduction in complications and revisions. This is just looking at a compilation of papers, looking at the Mazor robot versus freehand with 2D fluoro, where you see a fairly significant reduction in complications and revisions together, and then reduced radiation exposure as well, moving away from freehand with 2D fluoroscopy. This is just some evidence from a study out there comparing a robot platform to freehand MIS and freehand open. And when you look at just complications versus the robot, there's about a 3 times odds of suffering a complication MIS or open versus the robot, and almost a 4-time odds ratio of a revision with a freehand MIS versus almost a 2-fold with freehand open. So again, just showing that in a little bit more of a data format, significantly fewer complications and revisions with the robot. And this is some data from the refresh study. Again, this is a prospective study comparing a robot to freehand 2D fluoro. And again, just looking at some of the data, looking at the odds ratio of a complication or a revision of robot versus fluoro-guided MIS, there's about a 12-fold odds ratio of a complication and 6-fold odds ratio of a revision with fluoro-guided MIS, almost 80% reduction in fluoro time. And if you look at a Kaplan-Meier curve looking out to a year and looking at percent complication free, there's about 57% complication free on fluoro-guided and about 95% robotic guided. So again, just looking at some of the decrease in revisions and complications in these. This is a little bit of an older slide. It used to be that there was very little literature out there on robots, and now this is showing 300 articles. There's many more of that if you look today on PubMed. Just a significant number of authors publishing their experience using spine robots. This was just a prospective paper from just a few years ago. And again, what they found, the differences largely in their robot versus fluoro-guided, a significant reduction in radiation, which we saw and knew already. But I think an important part of this paper is because you can plan your screws, they saw a significant decrease in proximal facet joint violation. So could this have an impact on adjacent level degeneration? Yet to be seen. But if you can keep your screw out of that proximal facet, we may be able to reduce adjacent segment disease. And again, just looking at accuracy, really we want to be in a grade A or B screw placement as being accurate, and a significant difference of almost 99% versus 93 or 94% in freehand between the two platforms. So more accurate screw placement with these. And then since there's more literature, we're seeing systematic reviews. Here is one from 2018, a systematic review by Alex Gnaam and his group. And they looked at 32 articles at this time, and they found sort of when they looked at those 32 articles, the interparticular accuracy and complications were at least comparable, if not superior in the robotic cohort. So that's probably true, so better accuracy. There is evidence, though, that the total operative time is longer in robot-assisted surgery. That makes sense because a lot of these are early experience papers, but that seems to get better over time. The radiation exposure is variable, but it did decrease in the robotic arm as the total number of cases ascended, and so there's a learning curve. And when you look at multi-level procedures, at least a trend towards earlier discharge in patients undergoing robotic spine surgery. And that's important because you need to justify the purchase of one of these products in US dollars, about $1 million more or less. And so you've got to be more efficient in a way using these systems to justify their cost. And if we can get patients out of the hospital earlier, perhaps that can justify their cost. Certainly if we can reduce revision surgeries, that can justify their cost. But there's really just a trend towards shorter length of stay in the multi-level procedures. So now what's important here, I think, is you can look at the literature and look at a robot reducing revision rates, screw misplacement rates, your fluoroscopy usage, but you've sort of got to look within your own practice and understand what your own rates are and screw misplacement rates are. And I use this as an example. When we made an argument to buy a robot at the Cleveland Clinic, we used the argument of revision rates and screw misplacement rates. And our financial officers came back and said, well, why don't you tell us what your revision rates for screw misplacement? It's actually incredibly low. So if you're already placing screws fairly accurately with whatever system you're using, it can be somewhat harder to justify the cost of a robot. So you've got to go back, I think, in your own practice and try to understand what these rates are and does it justify your cost. Now, obviously, there are limitations to these robotic platforms. Probably one of the most important is cost. Again, in US dollars, these platforms are over $1 million. and you've got to justify that added cost to the hospital. Now, if I can reduce revisions, because I have a number of revisions due to misplaced screws, that will help justify the cost. Can I get patients out of the hospital faster? Again, that is questionable if a robot can help you do that, but if it is true in your practice, that could justify the cost. How much does your hospital take radiation exposure to surgeons and the OR staff seriously? If they really think that that is a big deal and they want to reduce that from a safety standpoint, and then perhaps a robotic platform can do that. So I think cost is the biggest limitation or barrier to them. There is a cumbersome workflow. It is a big system you've got to bring in. Depending on the system, it's either going to be attached to the table, it may be added to the floor, but you've got this arm working in front of you. And so it's going to add time, it's going to add equipment early on, it's going to slow you down in the operating room a bit in the beginning, but over time, can this improve your workflow as you move forward? And again, it is a piece of machinery, it's technology, it can err, and if we go on and trust these things 100%, that can result in a clinical error. And as Ed Benzel has always taught us, a fool with a tool is still a fool. So even if you're a bad surgeon, it does not necessarily mean that a robot's going to make you a good surgeon. So you're missing the cognitive aspect of this. And so we've got to keep that in mind when we apply these robotic platforms. And again, I think robots in the spine are in their infancy. When you look at sort of the advanced aspects of maybe what the software can do, again, as I showed some of that can, you can do advanced planning, you could plan all of your screws, you can make deformity correction measurements on your planning software that will allow you to place different size cages, perhaps perform osteotomies in different areas and see how that's going to impact your plan. You can have the robot design a rod bend for you as well through the platforms. It's not just placing screws. You can use the robot to help place MIS tubular retractors, both posteriorly in the lumbar spine and in the lateral aspect. And as I showed before, you can navigate your cage and plan your cage placement. When we looked at that transforaminal interbody fusion, again, the robot can help gain access there and navigate you to that area safely. Many of these systems are taking on augmented reality, where you can look through augmented reality glasses. You can see your plan in real time. You can look through the patient and see their anatomy projected on your AR screen. You can plan trajectories and perform that through the robot. And then ways to make the robot work more effectively is through artificial intelligence. And perhaps we'll be able to use these robots remotely as well, as the Da Vinci can be used as well. So these are just ways that in the future, these robot platforms continue to change. So in conclusion, again, I think we're seeing robots gaining significant foothold in spine surgery. Today, their application is somewhat limited, largely in the lumbar spine for degenerative pathology. That's probably the widest application. But if you look at what they could do in the future, I say limitless. There's never a limitless. There's always going to be a limit, but the technology is going to advance and hopefully make us better surgeons. And again, I think the question I would ask is, are we going to move more towards a cognitive specialty in a way from some of the physical aspects of spine surgery, let the robot do that, and we can focus on sort of our thought process and how to do these surgeries more effectively. So I think I'll stop there. And again, thank the audience for their attention. Thank the board for allowing me to give this webinar, and be happy to answer any questions.
So do we have a few minutes for some questions? If people can, in the chat, type in some questions. Salman, is that how you'd like to run it?
Yeah, perfect. If people want to raise their hands, we can unmute them and they can ask questions, or they can write in the chat, whichever way is fine.
Yeah, I can open up the chat box too. Are you going to moderate the chat box, Lily?
Hello, would you like to comment on this excellent presentation?
Yes, definitely. Thank you, Mike, for this great overview and very comprehensive overview of using robots. And I don't want to play the devil's advocate, but I would say that the majority of advantages are coming from navigation and not from the robot. So most of the advantages that you say about planning and doing and choosing the screw and playing with the rods and all of this, it comes from navigation and not from the robots. Don't you think so?
Yeah, I think Paolo, you're correct. I think, in my opinion, the power of this system is in the software development, which is, I think, where all the advances are happening, which is in the planning process, using things like even the future augmented reality, et cetera. You're right. It's not necessarily the robotic arm, but it's more or less in the software. So you are correct. I think the difference with the robotic arm, though, is really we're all trying to become more predictable in what we do, right? And so even with, in my hands at least, maybe not yours or other people in the audience, but certainly myself, when I use navigation, there is still some variability in placement of the screws, right? So meaning that I can place a screw accurately in a pedicle with navigation, but I may have some differences in my starting point level to level, so when I line up a rod, one's off a little bit. I may have screws, and you could argue that this is not important, but screw height, differences in height, et cetera. I think with the robotic arm, though, you can probably take away that variability, right? You can sort of plan it exactly where you want it. The robotic arm is going to move to where it should be, and you can place the screw. So if you argue that that's important, now that's the hardest argument to make, right? So I can't tell you that how important that is, but I think we can at least become more predictable on where we put our hardware using that robotic arm. It's probably a little bit more consistent.
Sorry, Lily, can I ask a question just in the same line?
Absolutely.
Okay, Mike, so basically we can plan that even on our image guided systems. We can plan that beforehand and do it exactly the same way, except that robot doesn't come in the end. So, if you plan it well, just like you're saying, you plan well, so that part comes in. The biggest problem that I see in image guidance or with robot is how accurate our input into the computer is. And that is how much of movement there is thoracic spine, is the movement of the respiration, is a huge patient, or we have a huge tummy and we push the patient away while putting in screwing and all that. So that changes, and the accuracy changes accordingly. So there are many factors that come into play. So
yeah, and I think. Oh, go ahead, Solomon. I apologize. I cut you off.
Basically, what I'm saying is that I think a majority of these things can be done with image guidance if you plan it well at the moment.
Yeah, I agree, and I think some of the downside with the image guidance systems now is they've become so quick. So if you go back before. A lot of the image acquisition in the operating room nowadays, like the O-arm or some of the CT scanners, when you had a preoperative CT scan that you would upload into the system, and then have to do a point-to-point registration, it almost forced you to plan the operation ahead of time, right? So you planned it. Now with, like, say, for example, the Medtronic O-arm, everything is so instantaneous, right? You get the image and you can navigate like a minute later, and so there's now a rush to do that. So you can navigate accurately, but you lose the planning process. So I do agree with you. It's if you do plan as you had said, yeah, you can do essentially a fairly equivalent type procedure. Now, I guess the other thing too is just to highlight what you said with error of accuracy. Now, these robots all have shown to be accurate, and all of the product information shows them to be accurate the way they navigate themselves, but it's a whole other degree of potential inaccuracy, right? So it's not just the navigation of your tool that you're watching a nav, but the arm has to be accurate as well. And so it's another level. And then there's things that you don't think about, because when you navigate with, say, a regular navigation system, you have sort of a haptic feedback, right? You can tell if it slips, if it moved, if you're drilling accurately. Say, for example, with the robot, you're sort of taking for granted, that you're going in the right spot. You don't have that haptic feedback. And so, there are issues with some of the arms of skiving off the pedicle, sliding down the side, you not knowing it, because you can't feel that. And so there are those concerns that are maintained with accuracy. And I think it's just getting in, using it, and sort of developing that workflow. I think when you look at spinal navigation early on, it was not this hugely widely adapted, system, right? Oftentimes hospitals would get them, they'd sit in the corner of the room for a long period of time, and now they've become more of a standard. And I wonder if now I don't know the answer to this, but I just wonder if spine robots 10 years from now will have this webinar, and this will just be what we normally do, just like navigation.
Mike,
Doug, what do you think?
I was going to say, Mike, can I ask you a follow-up question to that? There is, with new technology, especially when it's sort of on the developmental cusp, there is a learning curve and a time investment. Can you comment on sort of with experience, realistically, what you see? Do you think that the time will be very similar to standard timing for doing a case? Do you think that the pre-planning time will speed you up, etc.?
Yeah, I mean, I think there definitely is a learning curve. And how do I say it, Doug? It's flat, right? The learning curve is flat, meaning that it takes a long time to do this. This is Doug's big point here, so I got to make sure I do this correctly. So, Lily, I think it's more than it's more than just learning the system. It's also the cumbersomeness of bringing in all of this equipment into the operating room. And if we look at just our experience with the O-arm and bringing that in, I mean, it took quite a while till we now, and Doug, I would argue that we've got a pretty efficient system now, depending on the technologies we use, where you can bring the system in, you can, get your scan done and you're ready to navigate fairly quickly. But that took quite a long time to get to this point. And because you're going to need more than just you need a technologist to help get the robot in, get it set up. So, so there definitely is, I think, a longer, flatter learning curve to this. Less so of the technology of like planning it, but I think more so of just how do you integrate this system into your workflow so that you can become efficient. So the argument to buy one of these things is to become more efficient. You probably early on become much less efficient, or you decrease your efficiency. You're adding OR time. You're actually adding cost till you become more proficient at it.
So just another comment. I read a paper a year ago that somebody came up with this suggestion that it was cost effective to have robot eventually in the long run over a 5-year period with reducing the number of reoperations. So,
I think Salman, I think that the truth there lies in your own practice. So meaning that if you have, and there is a break-even point, like you could calculate this, right, depending on the cost, because we know what it costs for revision surgery and we know what the robots cost, but you have to have a certain baseline of errors with screw placement that you're revising in order to do this. So if you're already a good surgeon, such as yourself, and you're not misplacing screws, it's probably never going to be cost effective for you. But if you're a bad surgeon like me, who misplaces a lot of them, and I have to take these patients back, it can be an added advantage, So, but I think that is the problem: is you have to argue that it is cost effective either through reducing revisions or having patients get out of the hospital faster, or decrease your length of stay or something like that. You've got to have something like this change in your practice to argue that the added cost is a benefit. And that is, I think, the difficult part of this in acquiring these technologies in a rational way. Now, unfortunately, what we're seeing, and I'd be interested to know what it's like in other parts of the world, is what we're seeing is a very irrational expansion of these robots, where it's just like if the hospital down the street gets one, then the hospital across the street for them also has to buy one, because they're competing with each other and they're competing for practices in a very capitalistic environment. So we've seen a great expansion of these robots very early on with very little proof that they were effective. And so what we've seen is an irrational expansion, and I wonder how it's like in the rest of the world if these are similar issues that are seen elsewhere.
In fact, that's a perfect segue. I was going to push the system on our Zoom meeting today to see, if we could do a survey, how many people use image guidance for screw placement, and within the group, is there anybody who is using robotics or has had any exposure or experience to robotics? Salman, can we do it with hand raising?
Yeah, I think we have to tell people to go on their go on to participants list at the bottom. And once they're there, it says you can raise hands. So what's the question? You have to ask the question first.
Maybe if I unmute, the question will come through. The question is, how many people are using image guidance for screw placement currently?
And you would ask them to raise their hand in the chat box to
Yeah.
show that.
So you go to participants, and then there should be emojis for hand raising. Salman, you help us through this. 5 participants raised hands.
I don't know how to do it, so.
Yeah, exactly. How do you raise your hand? This will be our problem.
Okay.
But
the other option is to put your camera on.
Yeah. But Lily, your point may be valid, because even when we're talking about robotics, I mean, we still see challenges even on image guidance. You know what I mean? How many people are still using image guidance? Even you look in the U.S., it's become much more popular, but it's still many areas have not even adopted them, and a lot of it has to do with cost. Again, these are expensive systems. Some hospitals can't afford them, and others feel they don't need them. But I just wonder if it's going to become standard. So in India and Portugal and Greece and Pakistan, is image guidance commonly used for screw placement? And if so, I just wonder if I wondered in my own practice, where we do cases where we don't use image guidance for screw placement, and then we use it in a lot of cases. And if I misplace a screw freehand and damage a nerve, is that something I should not be doing? Because right next to me, I have an O-arm and I have a stealth navigation system, and I could have put that in more accurately. Am I committing an error by not using it? And I throw that out to the board here. What do you guys think?
I think the image gives you almost as many wrong placed screws because somebody bumps the arc or something moves. I did my first robotic case in 2003 with the original Mazor robot.
That's right.
It was incredibly cumbersome. I hated it. What I see looking at this, I love all these studies everybody prints comparing robots to freehand. But that's not the comparison that matters. If you're in an institution that has the wherewithal to buy one of these devices, what the comparison isn't robot to freehand, the comparison is robot to nav.
Right.
And that's the thing. I don't think that anybody is ever going to show a difference in outcomes comparing robots to nav. And so then it just becomes a matter of what else are you getting with the technology? Currently, you have the ability to do, the planning is the same whether you're using nav or robots. Where I see the potential for robots is when robots can start doing some of the surgery more than just being an advanced drill guide.
Yeah.
So
yeah.
You show me a robot that can mill a pre-planned posterior column osteotomy or pedicle subtraction osteotomy. That's where the robot starts to become an advantage to me. And that's the sort of leap in technology it would take to get me to stop using nav, because as you said, we have nav down now, so it's very, very efficient.
Yeah.
Why would I make myself less efficient for no benefit? There's no logic to that.
And I think that's been some of the argument against robotic platforms, is it's going to slow you back down, and is it really giving me an advantage in the technology that you have now? And I think, again, if you're a proponent of it, and you've got to be a proponent of it, I think you get into a robotic platform for what it's going to do tomorrow versus what it's going to do today. You're right, because putting in a screw at L45 may not be.
This was the argument that Izzy was trying to foist on me in 2003.
Yeah, that's right. That's right. That's right.
That was 17 years ago, and we're still in the same discussion.
Same argument. Yep. So. And he was a big proponent and had a role in Mazor. And you look at what's changed from Spine Assist, which I think was the name of the robot you had, to the Mazor X now. That's come a long way.
Actually, it was, Spine Assist was the
Spine
original.
Assist, yeah.
Oh no, it's come a long way. The technology is much better, but again, it still hasn't proven to me an advantage over nav.
Yeah, and keeping on Doug's argument, I would say that I know that technology has to evolve, but I would be happy to have a robot, for instance, that in tumor and complex dysmorphic cases prevents me from drilling towards the vertebral artery or spinal cord or something like that. But at the moment, what the robot does is just being a drill guide. So for a drill guide, I understand your point, Mike, that the robot forces you to do a preoperative plan. So at the end, I would say that probably the screws look more aligned on or more perfect on an X-ray than on navigation, because when I use navigation, I don't do preoperative plans typically. So it's likely that one of my L4 pedicle is facing more upwards or downwards, but it doesn't really make a difference.
It's a lot of money for a prettier X-ray.
But as you guys said, look, if you look at what we had with point-to-point navigation 20 years ago versus what we have now, it's changed dramatically. And I bet if you had this webinar 20 years ago and asked what spine surgeons were going to be using navigation, people would say, "Why? Put my screws in perfectly freehand. I don't need this." And so, but I think everybody's point is valid. It's hard to argue that putting in L4-5 pedicle screws with and without nav, with and without robot is not a huge difference. But again, all of the technology is probably already developed where you can define safe zones and you can remove bone around critical structures, and the robotic arm will not allow you to violate that. You can use augmented reality, so I can onlay the anatomy and plan in augmented reality space and have the robot execute it. And so all of this is already, a lot of it's already developed, you know what I mean? It's just coming out slowly. So again, I think this would be interesting to sort of record this in time and play this back 20 years from now and see who was right. Is robots what we're going to be doing 20 years from now, is similar to image guidance 20 years in the past? And who knows? I don't know which way we're going, but it's just going to continue to get better and better.
I think one more thing is important is, there was another study which had shown a year ago, I looked this up, and one more thing, it showed that every time robot made a mistake, it was all over the place on the pedicle. So whereas when we make a mistake, majority of the time we are outside because we know the nerve is there, robot doesn't know the nerve is there. So, it would be all over the pedicle, but the accuracy, you're very right. What's happened from 2003 to now is that the accuracy has gone more than 99% now with robot. And you're right that it has improved a lot. And I think it's going to improve further. There's no doubt.
Yeah, you're absolutely right. I think with all the effort in this technology is all about guiding the image guidance arm and making sure it stays accurate, right? That's where a lot of their effort has been. So, but I think the big problem with what you said, Salman, is exactly right, is that you lose the feel. Like that's the thing that we train as surgeons, right? We do things with our hands. You have a sense when you're putting in a screw if it's right or wrong, and you lose that 100% when you do it with a robot. And that is some of the problem. And that's going to be a skill set that's lost going forward if robots become a more mainstream, application. Fine.
But perhaps it won't be so dependent on skilled and unskilled surgeons. Everyone will get excellent care. So that's probably the advantage. We have time for one more question. I see Nicolaus's hand is up. So if we can unmute his mic, and then we will move immediately to the quiz afterwards.
Hello, everybody. I'm Nikolaos Sirmos from Thessaloniki, Greece. It's a great pleasure that I saw my friend Douglas Orr. We met 15 or 16 years ago in the spine courses that Benzel organizes in the Mediterranean area. It's a great pleasure and a great honor. I got only to mention one thing. To have better technology, it's a privilege also to avoid legal issue problems, because here in Europe, we have also, and also us young neurosurgeons, we have also legal problems, maybe also in other parts of the world, because the judge asked, did you use the better technology that you can use about spine surgery? It's a very important issue, and it's a very, very important issue for the young spine surgeons and the neurosurgeons because you know the legal problems. It's a great disadvantage to knowledge and to all the outcome. Dear Douglas Shore, best wishes. A great pleasure to see you again. You are young.
Not that young anymore.
As I met you 15 or 16 years ago, and okay, I remember you with great pleasure also. Salman, greetings and best wishes, and congratulations for everything.
Mike, quick comment on legal implications, and then we move on.
Yeah, again, I think this is where the concern lies is if you leave robots aside and just take image guidance navigation. So, you know, is that now the standard? And I don't think there's a legal standard for that now, but, you know, if you misplace a screw freehand and damage a nerve and you have navigation in your hospital, is there some legal concern there? And there may be, but as Doug Orr just mentioned, again, you can misplace them with navigation as well. And I think that's the argument legally you could make. But again, the legal argument would become the standard of care. And if we start defining these things, these technologies as standard of care, then that is where it's going to sit. Like you're going to have to use navigation, or will we be using robots 20 to 30 years from now because that is the standard of care to do that accurately. It's all a possibility. I just want to leave with one last comment on robotic ability. So I did a study where we were putting a pedicle screw in a pedicle traditional plus a cortical trajectory screw in the same pedicle. Okay, so that can be quite challenging. We planned it on the robot, and I had a first-year medical student who'd never ever touched the human spine before put all of those screws in accurately, just to show that it has nothing to do with the skill of putting the screw in. It's the screw of it's the planning, and then the robot accurately lining you up to do that. So the skill of actually placing the screw was almost zero. It was everything else. It was the cognitive aspect of it. In a first-year medical student who'd never placed a screw before in their life.
Brilliant. Lily, if it's okay, I'll just explain what's going to happen with the quiz. Everybody, can you go on the chat and see there's a link that's given by Maruf, which is 5 messages above. So it's LNH, and it says, so it's kahoot.it. So this is, let's see if I can show this.
And it's very easy. I just got on.
Yeah, so kahoot.it.
I'm just going to explain to the participants what we're doing here. Coming up for the upcoming World Spine virtual meeting, we are going to have a quiz game, which we hope will be entertaining and educational and fun. And we're just trying to figure out how to do this technologically because we're used to doing this in a live audience setting. So what we're doing is we're trying a quiz program today. And Salman, once you're all on the Kahoot website, Salman's going to explain how it's all going to work. But we are asking you to give us a hand here, help us out in terms of trying out some technology to see how we can run this in a couple of weeks.
Okay, so thanks, Jack. What we're going to have is Maruf is our computer geek. He's going to show us. So this is the link, and that's the number code you need to put in to get in. So everybody, please get in, including all the consultants as well. The whole idea is that we are able to do this ourselves and see how it works. So Doug, Lily, Paolo, Mike, all of you can come in. Great. So all of us go in there, and then we're going to go through 30 questions. These are all about spine, different areas of spine, and we're going to select the top 5. Now, I would request the faculty to play as well, but they will not be included in the end result top people automatically. We'll move them away. So maybe you can play, but at the same time, let us know who you are so that we can move you out, and we make sure that the young people, the residents and the trainee play at the end. So 30 questions are going to start shortly, and you need to just go on your cell phone and answer. The questions will be coming, and they'll be staying there for about 20 seconds, and then they go off. Maruf, are you ready? Has everybody connected? If then if there's a problem,
we got 58
let us know.
connected.
I'm connected. It
Just
just
a
says
cell
you're
phone,
in
or it
though.
can be in the computer. It can be in the computer or just a cell phone.
So you can do it on your computer on side by side
Okay.
as well, but if you do it on your cell phone,
Okay.
it's easier. Yes, if you are once
Okay.
you're in, once he shows it, then you'll be able to see the answers here.
Salman, it
Yes.
says you're in and it says see your nickname on the screen, but I have nowhere to answer that question.
So you do, they're asking, do you, yeah.
Yeah, but I can't affirm.
Maruf, can you unmute yourself and just tell us, is there any, do we need to affirm or we just go in?
No, you don't need to do anything.
Yeah.
So we just need to answer. Answers will come automatically.
Answer will come automatically when I start the quiz.
Nicholas, you can give yourself Nick the Greek god as nickname.
Just the name that's going to appear on the
What is the
screen.
nickname?
You choose whatever you want. You say Greek god.
It's just the name that's going to appear on the screen.
Like Doug's nickname is Or on the screen. You
Yeah.
can see the screen.
Okay, are we all set, Maruf?
Yes, sir, we are set. I'm starting the quiz now.
Okay, let's start the quiz. And so this is going to start 30 questions straight. Maruf, you don't have a music? No? Maruf, can we have the music as well?
Tight race at the top.
Posterior fossa.
Doug, all yours. So
Paulo
these are
pulls
your
it
top three.
off.
Okay.
You sort of pulled it out at the last minute there, Paulo.
Okay, what about Maruf? How can we see the top 10? Maruf?
I'm sharing it, sir, in a minute.
Okay, all right. So he will have the top 10 people out there. Obviously, we will discuss about pros and cons and the issues in the comments that we have had in the chat box. At the moment, our famous Paulo Pereira. Are you winning, Paulo?
Yeah.
So everybody's saying congratulations to Paulo.
Yay, Paulo.
Yeah. Well, I knew some of the questions, right? So it's kind of fitting.
Okay, and Rafa is
So
actually.
the idea is doing div on the eve of our events, right?
So what I'm thinking that, you know, because I just heard about, Salman and I
can we
talked about
discuss-
this before. Actually, maybe we should do this on the side later. We'll talk about.
I was going to say,
Yeah,
how about I
once-
close the
once-
meeting?
Yeah.
Yeah.
Okay.
So let's see the top
Okay.
10, and then we'll have another 10 questions through those top 10, hopefully with the music. People who don't like the music, they can mute it themselves. And people who like it, they can keep it. So I think for time being, it's good fun for us. Here we are. So Paulo gave 67% right answers. Very interesting. And 2 unanswered.
I made
Paulo,
the
what
top
happened
10 with 50%. But I got points for speed.
But I must tell you,
Okay,
there
that's
must be some
nice.
cheating because you know, one of my SR is in there, and one of my resident is in there in the top 5, 6. So probably.
Then you're doing a good job teaching them.
But I suppose these are the questions that we ask every day, so that they thought these are important questions to put them in. And plus, Paulo gave some, and we got some from Greg's Jeopardy questions, which we have for the final thing. Anyway, so these are the top 10. So these top 10 will. Oh, Pragnesh Bhatt is there from Scotland. So good to have you, Pragnesh. Pragnesh is our dear friend who connects in all our webinars. So we're going to, the top 10 are going to play again. So are you going to give a separate link to these top 10, Maruf?
Yes, sir, I'm sharing it.
Where will you share it? Private chat?
On the chat of the Zoom.
On the chat privately to these top 10 people. Okay.
While we're waiting, I'd like to thank everybody for participating. I hope that everyone found this a useful exercise. As Salman said, we will definitely review your comments and thoughts about the exercise, things we can improve, things you really liked about it. So please chat to me either privately or to the group globally so that we can enhance what we do next time. Thank you all. Are we ready for the top 10?
Everybody, top 10 people got it on the chat?
Not quite yet.
Salman,
Okay.
I
Yes.
have, there is a question about when the webinar will be evaluated. So before we close, can we also, once we do
Yeah.
the top 10, can we be prepared to evaluate Mike's webinar, allowing people for feedback?
Emad, can you please send that link as well, please? Pragnesh is saying that he hasn't received the link as well, so we have to have 2 links, one for feedback and one for 10 people who are going to participate.
I'm on, but I've listed as no players.
So you're already in. Okay.
Or is there a different link? So I've got the game pin 388568.
Yep.
Let me see if I
That
can
is
get
the
in
link
with
for-
that link when I'm not supposed to.
No, because obviously you will get in, but this link will be shared only for those top 10 at that time. So he's just
Okay.
shared
Okay,
it there, shared it there.
there's 11 listed now.
I didn't do
It's
it
okay.
yet.
Yeah.
It's okay if 11 are playing, we don't mind. It's
Okay.
okay. So can we start? And I think we'll have to choose the kind. Lily, we'll have to come up with good music here now.
Okay. Next time.
Okay, done. Where is Paolo in there? I don't see Paolo. Paolo, you haven't joined.
How is there? How?
You put in the new pin.
Did
You have
you
to put in a new pin. You go
Okay.
back to the
So,
Kahoot website, put in a new pin.
Okay. 3, 8, 8, 5, 6, 8.
Either that or we could just play without him and then he can't win.
Okay, that's a good idea.
For all the participants that aren't in the top 10, we'll be happy to hear your feedback, whether this is a useful part to watch, whether it makes sense to do it that way. So any feedback is good feedback.
But
Okay.
what are we doing now?
You're doing it again for 10
10
questions.
more questions to decide
10
who really
questions.
wins.
Okay.
Top 3 are
Okay.
going to be picked up from here. So you
Okay.
get scores for replying early as well. So then you make mistakes as well. So that's the way to do it.
Okay.
Okay, can we start? Maruf, please. You need to click on start.
Okay, here we go.
Paolo winning again. Answers with okay. that's brilliant. Thank you, Maru. Thank you for sharing that. Congratulations, the top three. Doug, you're going to announce the top three, or shall I?
Go
announce the
ahead.
top three? Maru, you want to announce the top three, please, since you played it? Okay, Mike just lost his internet connection. He's coming back in. That's why he lost, actually. So we have Maruf, you're going to announce them, please?
Yes, first position by Yasir, second by
You
Dr.
don't
Das,
announce like that.
and
You said the first position went to Yasir K.
first position went to Yasir K.
Congratulations. Okay, well done. Second is Dagor.
Yay.
Yay. And Yasir Ashraf is third. Well done. I think these guys will get certificates from World Spinal Column Society for coming first, second, and third.
I can pass on this certificate.
Professor Orr,
We'll keep you.
We will. Lily, could you frame that and please put it in his office? Okay. The other thing, can everybody open their videos? So we're going to have a group photograph before we go on to our World Spinal Column Society board meeting. So rest can switch off. Can everybody please switch on their videos? So we have a group photograph. Thank you. Maruf, you as well. Thank you. Thank you. Sandeep, you have disappeared. Are you there? Please switch on. Everybody switch on their videos. We
Is
need more
Mike back
people.
yet?
Mike hasn't joined. So you want to call him and see, is he connected? Is he having trouble?
He texted us.
Okay. Noor has joined us as well. Hi, Noor. Good to have you. Brilliant. We are still waiting for Mike. He said that he's joining. Can you try calling him, Lily, before we take
I
a group
just
photograph?
texted him to say, are you almost there? Group photo.
Okay, let's get a picture. Once he gets in, we're going to get him on top, and we can get him with that as well. So, Imad, are you there? Can you take the picture, please? Imad? Imad is not there, so I'll take it. Okay.
He's
Can
resetting
everybody
the.
smile? Everybody's so serious. Please, can
Yeah,
everybody smile?
Mike's not going to be able to make it. He's having to restart the router in his house.
Oh, okay. No worries. Thanks, everybody. And both the moderators, can you please wrap this up so that we can go on to our board meeting?
All right. Well, thank you, everybody. A heartfelt thank you to Mike for such an excellent seminar. And the fact that we went over time was just a testament to what an interesting and important topic this is, and something that we'll keep our eye on in the future. I appreciate everyone's involvement in our game. And Paolo, any other additional comments that I missed?
No, just to thank the presence and the participation. I think it was a lot of fun with the game, and we look forward to the next opportunity to meet.
And a thank you to Salman and his team for making this happen. So thank you all. Have a very good Sunday.
Bye-bye.
So please sign off if you're not on the board.
Okay. Can everybody please sign off? Who is not on the board of World Spinal Column Society? We'd be grateful. Thank you.
I asked Mike if he can sign on with his phone.
We can't have 43 people on the board. Imad, can you help people sign off, please?